Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, it's Dr. Nick Biasotto, the host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. And today we have a guest who's been on our program earlier with a previous podcast, is Dr. Richard Henderson. Dr. Henderson, I will not go into a bio on you at this point because we do have it on an earlier podcast. However, I will say Dr. Henderson is a previous president of our Medical Society. He is presently the chair of our legislative committee, which in my mind is probably the most important one of our committees in the Medical Society. And he and his committee do a lot of work, and I mean that, a lot of work, time-consuming, for the improvement of medicine on the both patient side as well as the physician side. And he's also a distinguished member of our Tilton Award. That's the highest honor you can receive from the Medical Society of Delaware. Welcome, Rich. How are you?
Thank you, Dr. Biasotto. I am well.
Good. All right. Today we're going to go through some of the legislative issues we're facing in Dover, and particularly, obviously, the ones that involve patients or physicians in our state. First, we're going to start with the prior authorization bills. I've done a podcast on that as an editorial. Really downplaying prior authorizations. I think it's a process that should be eliminated. We're working tirelessly to have this occur, and we're chipping away at it bit by bit. But the Senate Bill 12, the recent information regarding prior authorization bill down in Dover, and sponsored by Senator Townsend. Can you elaborate a little bit further about the prior authorization bill, where it stands at this point?
Happy to do so. Mm-hmm. Before doing that, I'd like to thank the members of the Government Affairs Committee. We meet once a month between January and July to consider the legislative activity. I'd like to thank the Executive Board for their support of the Government Affairs Committee. The entire Medical Society staff, led by Mark Thompson, and particularly Lori Ann Rhodes and Lisa Gruss, but the whole staff has been extremely helpful in helping us move things forward. And of course our lobby team, which is Bird Gomes and Lincoln Willis, which I think are top-notch and have been very effective in helping us both get things through and equally as important, putting a halt to some of the other things that would have been not so favorable. So Senate Bill 12 on prior authorization is the same as Senate Bill 6 that was introduced earlier. It had to be changed because of some technical issues, but the main components of it are the same. This is a bill on prior authorization that we partnered with the Delaware Healthcare Association on. We also had a sign-on letter that included 50 practices and community groups across the state. In working this year, we presented information or data from the AMA with regards to the impact of prior authorization on both patients and the practice of medicine. We also presented information from a Medical Society survey that mirrored the same information that's provided by the AMA. Specifically, Senate Bill 12 will improve response times compared to what they are now, limit requests to one per episode of care, and there are some exemptions there. It will increase access to clinical decision makers, expand access to peer-to-peer consults. It will require appeals and denials be reviewed by specialists in the same or similar field. It will require information be reported to the Delaware Health Information Network to improve transparency. And it will require State Employee Benefits Committee to ensure that carriers administering health insurance contracts under the state comply with the provisions in Senate Bill 12. And it will require DHSS to ensure, to the extent possible, that all their carriers administering health care plans and insurance contracts related to Medicaid assistance comply with the same bill. the latter two, both in making sure that the State Employee Benefits Committee and that Medicaid are included, are significant changes from the previous versions of prior authorization because of how important getting those two groups included is. One of the detriments to Senate Bill 10 from last year, which dealt with prior authorization, was the huge fiscal note that was associated with it. We did a lot of work to try to address the issues with regards to that, and for Senate Bill 12, the fiscal note is not an issue so far. For 2025, the Office of the Comptroller General determined that Senate Bill 12 and prior authorization would have no impact on the fiscal note. And on 2026 and 2027, it's undeterminable. Last year when we discussed prior authorization, it was the fiscal note that pretty much shot it down. Mm-hmm. Without that particular element in this year's bill, it has moved along a lot faster. The bill, Senate Bill 12, was opposed by AHIP and the PBMs because of the pharmacy component of it, which we felt strongly that the pharmacists should not be independent and be able to determine what occurs once a prescription is written, whereas they feel that pharmacists should play a role. Senate Bill 12 passed in the Senate with bipartisan support. There were 20 yes votes with one absent. It has gotten out of the House committee, but is now pending for a vote on the House floor. If it passes in the House, then it goes to the governor for his signature.
Okay. Is there any fiscal note that could be that much compared to what the fiscal note is for the physicians' offices throughout this country? I doubt it. And I'm sure that the insurance company's fiscal note to run the program isn't a cheap one either. So do you envision someday, Rich, that this process will be eliminated?
Possibly not eliminated, but significantly improved from the patient and physician perspective.
Okay.
Because I think the plans are starting to recognize that there are changes that need to be made to remove as many hurdles or obstacles for patients getting the care that they need. Mm-hmm. And right now the perception may be that the plans through their prior authorization process are more of a hurdle than there needs to be. So if what's occurring here in Delaware is occurring elsewhere in the country, as the AMA suggested is, prior authorization is a discussion that is not going to go away.
Okay, thank you. All right, the primary care reform bill. Now, as I've alluded to in the past, as well as you, primary care physicians are few and far between. Many of our primary care slots that residents have to match for after finishing medical school have gone abandoned, have not been picked up. So that means we're getting less and less of the primary care physicians in our country, which is, I believe, the foundation of medicine, and therefore, when the foundation cracks, the house falls down. Talk to me a little about Senate Bill 120.
Senate Bill 120 was passed in 2001 and was intended to begin to address some of the issues with primary care that you mentioned. It has not been as effective as we had hoped, and that has to do with what is written in the bill and then what comes out in regulations afterwards. Mm-hmm. We started paying a lot more attention to the regulation component of it. So the current primary care bill that's being worked on would begin to address some of the issues that were in Senate Bill 120. The first and most important one is to eliminate the sunset. Right now, Senate Bill 120 was sunset in 2027. So we have some time to make sure that that doesn't occur. And I'd like to shout out our primary care subcommittee for the work that they've done on this over the past year. We have met with legislators to discuss why primary care and why the primary care bill is important. And these are some of the elements that we've highlighted for them, that this needs to include both Medicaid and the state employees because of the populations that are enrolled through those programs. They need to be included in this bill. They were not included in 120. And that was a strategic decision because we were told that it had a higher chance of passing if you didn't include those two populations initially, with the thought that we would go back and include them later. We're now including them in the discussion.
Okay.
The new approach to primary care would include all persons in relevant health plans that are attributed to a primary care physician, and it would include those two populations that I mentioned earlier. It would require that all payments follow the patient to the primary care physician to whom they are attributed. From talking to our colleagues, that is not what is happening now and is problematic.
Can you explain that a little more?
As a primary care doctor, you probably know more about attribution than I do. But apparently, if a patient is assigned to you or attributed to you, right now you may not be, or primary care doctors may not be receiving the reimbursement that they should for the care that they provide.
Okay.
Now, I don't know if that has more to do with more of our primary care docs now becoming employed versus those in independent practice.
Mm-hmm.
Those are things we're continuing to try and work out.
Okay.
But the attribution part of it seems to be a major component of the discussion.
Gotcha.
The new primary care bill that we've been working on would also create a 5-year glide path for implementation, during which time the health plans would reimburse at a fee-for-service rate that's at an increased rate of Medicare, or have a robust prospective payment in place, and develop accountability standards for primary care. We've been working with Senator Townsend on the primary care bill for some time, and recently had discussions with the Department of Insurance, who indicated that they also have a bill on primary care that they are interested in moving forward. And it's waiting to be introduced, but the basic elements of it are similar to what I described above, but the Office of Value-Based Healthcare Delivery will create quality definitions and standards. Their bill would also address the attribution issues, but do it in regulations rather than in code, because it's easier to change regulations. When you have something in code, you have to introduce a new law, and we've seen how long that process can take. The Primary Care Subcommittee also voted, after having long discussions with the Department of Insurance, our Primary Care Subcommittee voted to endorse the Department of Insurance bill because it contains many of the elements that they would like to see in the bill.
Okay.
As of this morning, the bill sponsor suggested a possible way to get this introduced in the waning days of the legislative session, which are less than 5 or so now. And it has many of the elements that we've been discussing in both the DOI bill and the primary care elements that our primary care subcommittee has been working on. We are waiting to see what those final details of a different version may look like. So it continues to be a moving target, but we are going to pursue this as vigorously as we have in the past.
Should it all come down to what you've mentioned is in the bill and it's accepted and passed, does that involve all the insurance that all the payers have to oblige by that, or is it just state
and Medicaid
insurance?
Those that are fully insured, we hope will follow the lead.
Okay, good luck. Okay. Yes. All right, next, educational transparency. This is an issue in which a lot of people get their doctorate degrees, but they're not physicians. Nurse practitioners can get a doctoral degree, But we would like to know that when a patient is confronted by a individual health person, such as a physician or a nurse practitioner, that the patient knows who he or she is going to. Is it a physician, or is it a nurse practitioner, or is it whatever? And I think that's a good bill. I hope it goes through. I know that the Medical Society is supporting it. Is that true?
That is very true. This is the third of the three legislative priorities that the Medical Society has been working on for the past couple of years. So you're right. Educational transparency, or truth in advertising, is a concern because, as you mentioned, a lot of our colleagues are attaining higher level degrees, which allow themselves to use the term doctor. But as we know, all physicians are doctors, but not all doctors are physicians.
Correct.
How that is presented to the public and what the public understands, especially if it's their anticipation that they're going to be seeing a physician, has been a concern for a long time.
Okay.
Our effort is not to try and diminish the educational achievements of our colleagues who've gone on to get advanced degrees. We celebrate them and recognize them as being valuable members of the team, but want to be sure that the public is clear, especially if it's their anticipation that they're going to be seeing a physician, that the person who they're seeing who is able to use the term doctor is or is not a physician. Now, I will say that this is not an issue in most of the hospital settings because that's clearly identified on their badges. Mm-hmm. But in private practice and independent practices, particularly as those now who can have independent practice privileges on their own, when you walk into their office, is it clear that the person you're seeing is going to be a physician or not a physician? And so that's the tilt toward educational transparency. And so it means educating both our colleagues on this issue and making sure that the public is aware.
Okay. Is there any opposition to this from the nurse practitioners?
There has been some hesitancy to move this forward. Our original sponsor is a nurse. She is now the Speaker of the House. And so we have been working with her to address the concerns that from the nursing side that have been voiced about this. And we are hopeful that discussion will continue.
It's only truth in advertising. That's all it is. Okay. How about House Bill 3, breastfeeding within the Department of Corrections? Women that are incarcerated and want to breastfeed a child.
For all women's health issues that come up, we have a strong relationship with the Delaware section of ACOG, the American College of Obstetricians and Gynecologist. And on these women's health care related issues, we frequently turn to them for guidance, and this was something that they supported, and the Medical Society did the same.
Okay, now there's a very interesting one. I think we're going to pass on the licensing fees for the Department of Insurance at this point. But we have Tianeptine, which is also called the gas station heroin, which is available on the streets, and it's not illegal at this point. So I know there's a bill up to change that and to put in a Schedule I controlled substance category. What's your feel? What's it look like down in Dover for this?
The Medical Society supported banning Tianeptine being available, as you just mentioned, because of the significant side effects it can have. We provided testimony in both the House and the Senate in support of House Bill 21. It was reported out of the Senate Health Committee, but so far as of this point has not gone further than that, but it has Medical Society support.
I see it only being approved, don't you? I mean, that's only common sense for the damage that drug can do.
Absolutely.
All righty. Parental consent for minors seeking an abortion, that's HB 46. talk to me a little bit about that, and why is there any opposition?
The concern, I believe, this is comes to us from Representative Shute, and the bill is to ensure that their parents are aware of the decisions that their minor may be making.
Under age 16. Mm-hmm.
Under age 16. This comes down to healthcare decision making, and who has that capacity, particularly in this particular area, because of the current makeup of our legislature, who favors more independent decision making. This did not get released from committee. It is a subject that is not going to go away. It will come back.
It should, because I'm a strong believer in parental rights, and this, if it passes, that's okay. It's good. If it doesn't, we're overlooking parents as the ones who control their children. Okay, telecommunications services and devices for persons. It's House Bill 53. What's that all about?
Apparently there was funds set aside to address the this particular population of the hearing impaired, and that office is undergoing some changes, and those funds can now be used in other ways to address the same group, and that's what this bill would allow them to do.
More access to services for telecommunications for the hearing
Yes.
impaired. Okay, great. That's a no-brainer. We support that, I hope, right?
Yes.
Okay. Suicide prevention. This is House Bill 54, I believe.
Yes.
Establishing the Office of Suicide Prevention to address suicide prevention in Delaware, I imagine.
Yes.
Anything that we need to know about that?
It was passed in the House as recently hasn't gotten to the Senate, as far as I know. Something that we would, as physicians and the community in general, would obviously be in favor of, but hasn't moved forward so far.
Okay, I'm sure it will. It's just common sense, I believe. Now, this issue of House Bill 56, in which insurance coverage should be allowed for patients who have excess skin caused by either surgical procedures that made them lose a significant amount of weight, and that leaves what we call a panniculus hanging from their gut, which collects into bacteria, funguses. It's uncomfortable. It's a mess. I've seen patients with that, and I'm in favor of this being allowed to be covered, to have that excess skin removed. And do you anticipate that going through and passing?
It passed in the House, has not been moved in the Senate so far, but as you described, the benefits with regards to the health and hygiene, we hope so.
True. Okay. Suicide Prevention Coalition, House Bill 87. What do you take from that?
Also reported out of Senate Health, not much movement so far in the House, but along with the Office of Suicide Prevention bill for House Bill 54, we hope that this will go through.
Okay. We're not concerned about the bill regarding pay range transparency for certain job opportunities. I guess that could be Department of Labor. Discuss that in length. End of life options. House Bill 140. Talk to me about that.
House Bill 140 or the end-of-life options bill was introduced 6 or 8 years ago.
Okay.
And has been a topic of ongoing discussion in the legislature since then.
Mm-hmm.
The Medical Society's position on this is one of engaged neutrality.
Mm-hmm.
It was carried over again this year and passed, and it has all of the original same provisions as in the original bill, with one addition. This year's version made a technical correction to include the definition of physicians for consistency and clarity that a physician must be licensed here in Delaware.
Mm-hmm.
The bill also requires that the person requesting in this particular end-of-life option be a resident of the state. That bill passed last year, but Governor Carney opted not to sign it. It came back again this year and did pass, and the governor signed it on May the 20th of this year.
So medical assistance in dying is now a law in Delaware.
Delaware becomes the 11th state in the country
to do it,
to allow it.
Yes. Is D.C. in that 11 number? Washington, D.C.? Is that
They're
12?
not a state, but they're 12. They're included.
As the 11, in the 11.
Yes.
Right?
Yes.
Okay. Now, the logistics of this has to be worked out, obviously. We do know that it takes 2 physicians or 2 advanced nurse practitioners to declare that the person is terminal within 6 months, and that can be and it is a significant pain, and that can be an option for controlling the situation and helping an individual, ease their pain. Right. Now, discrimination based on body size. This I find interesting. This Act, House Bill 115, prohibits discrimination based on weight, height, body size in transportation, public accommodation, housing, commerce and trade, employment, jury selection, education, and public administration. In regards to House, you want to offer some more information about House Bill 140.
Another important aspect of this bill relates to an editorial that was published last year in the News Journal, I believe, that indicated that the Medical Society would be doing training for physicians who wish to participate in medical aid in dying. That is not correct. We have asked and I testified in the House hearing on this, that the Medical Society would not be providing that training, and have requested the News Journal to provide some type of correction to that editorial that, as of now, I don't think has occurred.
No, it hasn't.
But wanted to be clear that for those that are interested in doing this, that this is not something the Medical Society is going to be training folks to do.
Well, the logistics still have to be worked out, as we know. We've just mentioned a few of the details about those that qualify for for considering medical aid in dying. But the logistics of it all, for example, if a doctor does not want to provide the medications that could ease the pain and suffering of a person who's terminal, there have to be some way that person can get the necessary medication to complete the job, as they say, and that would be available somehow, some way through individuals that will be doing that.
Yes, DHSS, I think, is charged with creating the mechanisms for that to occur.
Okay. Mm-hmm. House Bill 149, mental health at school-based health centers. Talk to me a little bit about that, Rich.
That also passed in the House, has not, as of this point, gotten to the Senate process, but as you said there, would give the Division of Public Health the authority to approve supervised clinical training rotations for mental health providers at school-based health centers. We are monitoring this, and if we are asked for an opinion on that, I don't see that would be anything that would be opposed.
I think it's very important that we have supervised clinical training for something like that if it's going to be used for our children in school. All right, diabetes wellness pilot program. This sounds interesting to me, and I don't see where this is going to provide a problem. But can you go into that a little bit?
Absolutely. Representative Hilofsky is the primary on this, and his intent is to begin to translate our system from being sick care to wellness care and using food as medicine, so to speak, particularly focusing on the diabetic population within the State Health Employee Benefits Plan. Mm-hmm. Last year, a staggering amount of money was spent through the State Employee Health Benefits Plan on diabetes alone, and to help reduce the cost to the state, as well as improve the health of those with diabetes. Representative Hilofsky has put together a plan to do a study to see how using food as medicine can reduce both diabetes, help those that are pre-diabetic, and in some cases, hopefully even reverse diabetes by looking at what they eat, how much of it they eat. But this will require a partnership between a Delaware health system and a technology partner that would be working in conjunction to regularly test, measure, and manage, and help to incentivize patients with diabetes or prediabetes in monitoring their condition. This would occur over 3 years, during which time that data would be tracked and then reported out as a pilot program to see how effective it is, and if it is effective, expand it beyond the state employee health care benefits population to the general population.
I think it ought to spill over into our schools. Our kids are not given adequate food. If they eat breakfast and lunch at the school, most of the time it's pretty unhealthy stuff. I imagine it's cheap, but it's still not healthy if you want to consider the long run and the health of that child.
So we've had considerable discussions with Representative Hilofsky about this, and I think everybody recognizes, and the studies prove it, that what you eat is an important component to your health. Mm-hmm. What's also important to understand is that eating healthy as healthy as you can is not inexpensive, which for a lot of the population who may be affected by this may have some difficulty with.
Got it. All right, dry needling. This is an interesting thing. It's House Bill 165, which they use dry needling as therapy to relieve pain and muscle spasms and neurological pain caused by neuropathies and things like that. Talk to me about what is going on with the bill. I mean, dry needling is effective, but what's going on with the bill?
This bill would have allowed occupational therapists and occupational therapist assistants to perform dry needling, which they currently cannot. Physicians' assistants and physical therapists, physical therapists can do this, but physicians' assistants cannot. The Medical Society opposed this bill because of the extension of allowing occupational therapists and their assistants to do it. Discussions with the sponsor of the bill seem to be pretty effective, and both the occupational therapists and their assistants were removed from the bill, but nurse practitioners were added. We're having ongoing discussions with the sponsor of the bill about this, and as of this point, it has not been heard in either the House or the Senate committees so far. Okay. But it's something that the Medical Society has initially opposed and will continue to monitor.
Okay. Then there's a surgical smoke bill, House Bill 173. You can go with this any way you want, but go ahead, Rich.
This was a bill that came to us from the Delaware Nurses Association, where they voiced concern that some of the members were reporting that they did not have the necessary equipment in some settings where surgical smoke or plume was created, and felt that it was a safety hazard.
Now, surgical smoke, let's define that. That's cautery, instrumentation, things like that, where you want to stop a blood vessel from bleeding, and it does release smoke.
It does.
Okay.
And apparently some members in their organization felt that where they were working did not have the necessary safety equipment to do so, and
Got it.
we were happy to work with the Delaware Nurses Association in supporting this.
Okay, two more in the House bill, and then we'll be moving on to the legislation, Senate bills, but we'll have a break in between. But healthcare services, talk about that a little. House Bill 205. This seems to be important to me, I think.
It is. In some states across the country, they are passing legislation that allows their justice system to pursue patients from their state that go to another state to have certain health care services provided. Those states would allow them to not just pursue the patient who went out of state to have this done, but also go after the physicians or other providers who took care of that patient. So, for example, if someone from Texas came to Delaware to have something done that is legal in Delaware but illegal in Texas,
abortion issue, right?
Or
sex change,
whatever the case may be, the Texas law would allow them to pursue not only the patient who came to Delaware to have the procedure done, but the physicians or the people who cared for him or her here. This bill would provide protection for the medical community who would have taken care of that patient.
And the patient themselves.
I think there's already something previously that would protect the patient. This specifically goes to the point of protecting the team that provides that care.
Understand. Overpayment and recovery and audits. This is interesting too, Bill. What is this? House
Bill 212 comes from the Department of Insurance, who we are happy to partner with again. Looking at the ability of insurance plans to, I guess in the physician community we call it clawback payments that have been made for services that were delivered.
Mm-hmm. In other words, you're paid X amount of dollars for the procedure that was done, and the insurance company says you were overpaid and wants to claw it back, but they only have a limited time to do that. Is that correct?
Well, now the window is 24 hours, and their ability to do so is based merely upon a reasonable belief that fraud, waste, or abuse has occurred. House Bill 212 would require them to have proof that something like that has occurred before they can initiate that clawback process.
Well, let me ask you this. That would work. Let's say a surgeon does a procedure, receives a certain amount of money that he feels he should deserve, and sometimes surgeons have no idea what they're getting in from the insurance company. It's in their billing service and goes into their bank account, and that's about it. How would they be able to prove that there's something fraudulent in that activity?
It would require a factual analysis of that data.
Okay.
Right now, they have the ability to say, we believe.
That's it.
That's it. That's the way the current code is written, that if we have reasonable belief that there's something occurred here, that you were overpaid. Right now, if Senate Bill 212 passes, that will require an actual audit before they can start to
claw back the money.
Right.
Got it.
And it also reduces that window to do it from 24 months to 12.
Got it.
So significant changes that will provide hopefully a little bit more stability and predictability for physician offices where this could occur.
Got it. Okay, before we get to the Senate bills, we're going to take a little break and we'll be back shortly.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, this is Dr. Nick Biasotto. We're back from our break talking with Dr. Richard Henderson regarding issues facing the physicians and patients in Delaware coming out of our state capital, Dover, and the legislative body down there. All right, now we're heading into the Senate bills. We've completed a lot on the House bills. Now we're going to the most important in our mind, Senate bills. And the first one is SB, Senate Bill 5, Right to Reproductive Freedom. Talk about that to me, please, Rich.
So this would enshrine certain protections and rights with regards to women's health in the Delaware Constitution. To change the Constitution, our state Constitution is similar to what's required at the federal level, that it has to be introduced and passed in both houses, and it has to occur over a certain period of time. This was the first leg of trying to change that or getting it introduced into the Delaware State Constitution.
All right, you're sending that off, your committee is sending that off to ACOG, or the Obstetrician and Gynecology.
Delaware section of ACOG, and they will run it by the national office.
Okay.
These are principles that are consistent with the position that ACOG has taken in protecting women's health rights, pretty consistent.
Got it. Okay, second bill we're going to talk about is Senate Bill 41, red dyes. This is to remove certain dyes from our consumption, and I think that's a no-brainer, right?
Yes, well, and this specifically has to do with foods that are available to our children and through schools. It would not affect yet the rest of the general population.
I think that's coming from the feds sooner or later.
Apparently yes.
Okay, here's an interesting one. Senate Bill 55, the gender transition procedures. Talk to me a little about that.
This was introduced on the Senate side to, again, look at this particular population and prohibit this from occurring until a child reaches a certain age, because of reported incidents of those who begin that process and then later may have regrets.
What would be an appropriate age for that? Would you think 18 and above? I mean, rather than before that period of time? What's your general feeling? I know I'm not going to hold you to it, but I feel it should be 18 or above. I mean, when you at least reach the age of reason, supposedly. I don't think it should be done in 12 and 13 and 14-year-olds. That's just my opinion. And doesn't necessarily reflect the opinion of the Medical Society of Delaware. What's your opinion, Doc?
Making such significant decisions, you would think that the older you get, the more information you can digest and help you decide one way or another. Whether that's at 12 or 18, will that prevent you from having regrets when you're 25? Or so?
I would at least want to shove it off to 18, and he said at least they had some sense about him at that time. And I mean, I can't see a 12-year-old saying, I want gender-affirming surgical procedures done on me at that point. And I think my personal belief, again, is that, parents should be involved in this 100% and not just...
But this is another one of those bills where that discussion about parents' involvement comes in. Mm-hmm. And while this did not get out of committee, it's in that category of subjects that is going to return.
It'll return, I'm sure. Okay, the next bill, Senate Bill 69, is basically banning red dyes from schools, which we talked about earlier. So yes. That's a no-brainer, because they're finding that the red dyes are problematic. How about genetic counseling? Senate Bill 70. I, as a practicing primary care physician myself, know there's a lot of genetic information out there that I'm not up on, because it is quite extensive, and I've been a long way from my genetics training, and that there are definite specialists out there who are geneticists at heart and can help us with determining what genetic studies must be done for certain conditions, right?
Correct.
Okay.
the way the current statute is written is that genetic testing must be ordered by a physician.
Okay, myself, I would be glad to order it because I need the input.
But many of us, like you, who did our genetics in medical school and or briefly during our residency training, have not been able to keep up with all of the changes that occur, which are occurring more rapidly.
Got it.
And when this came to us, one of the other concerns was the delay in testing that may occur between the time a genetic counselor sees a patient and by when that patient gets to see a physician. Genetic counselors have to take certain courses and have to be certified to become genetic counselors, and they are much more aware of the type of testing that needs to be done that can be done in a timely fashion before the patient gets to the physician, and the physician has that information to help that family make decisions.
Good.
The Medical Society supported this, and
it's a no-brainer there.
Yes.
I think we have some good genetic counselors in Helen Graham. If we need their expertise, I've always asked for it if I go in that direction.
It came from us from Helen Graham.
All right, Senate Bill 93. This is third-party decision-making. This is interesting. Tell me about it, Rich.
This has to do with what is available for at the end of life for if not the patient, for whoever that patient is designated to be their surrogate in decision-making when they are no longer able to do so. This would bring Delaware up to code with previous acts that allow others to be involved in that decision-making process. This passed in the Senate. As far as I know, it has not moved over to the House yet, but would be, like I said, as I mentioned earlier, would make Delaware more compliant with other areas of the code.
Got it. Thank you. I'm going to move on to Senate Bill 110. That's physical therapy bill. As you know, physical therapists can now be hired to work for orthopedic specialists or any other doctor that so desires to hire on a physical therapist. That law was passed about a year or so ago. What's the purpose of this bill, 110?
Senate Bill 110 would extend the current referral time from 30 days to 90 days. So that means that a patient could continue to be cared for by a physical therapist if this passes up to 90 days without having a physician evaluation. Currently, that limit is 30 days. The Medical Society opposed this because the time spent between 30 and 90 days when a condition is not improving may put that patient at risk for having a worsened condition at the end of that 90 days when referral would be required. We also have some concerns that when referral does occur at 90 days, that patient may have exhausted his or her benefits, so that when they see the physician and there's something else needs to be done, they have fewer options. Senate Bill 110 was passed in the Senate, but appears to be on hold. We've shared our concerns with the bill sponsor and opposed it as written.
Got it. All right, behavioral health bill. That's Senate Bill 161. You talk to me about that, if you would.
Senate Bill 161.
In other words, they want...
this act authorizes Division of Substance Abuse and Mental Health to issue licenses to adopt and enforce comprehensive regulations for behavioral health providers and organizations and treatment programs.
Okay.
It will require the provider organization to obtain licenses to operate behavioral health treatment programs with exemptions of certain practitioners and programs. This suggested that prior to this bill, such programs could be operated without having any specific licensure requirements. This would bring them require them to do so and be reportable to the state, which is a good thing.
I agree. Well, that seems to wrap up the Senate bills, and we have just touched the surface. There were so many bills. Many of them seemed more important than others. We sort of picked out the ones we thought were most important to discuss. However, if you want to see more details regarding Delaware legislative issues, you can go to the Medical Society's webpage or website and go under legislative updates, and that will put you right on board with what's going on, and you can explore many of these legislative issues in more detail than we could time allowed us to do here. So thank you very much, Dr. Henderson. Appreciate all your input and all the hard work you do in this committee. You are a vital committee, and you are an excellent chairman. And I know that you know all of the legislative people down in Dover, and that gives you a little in with what you can do for us in the future and the patients of Delaware. Thank you again, Rich.
Thank you, Dr. Biasotto. I will again thank the members of the Government Affairs Committee for all the work that they do. Again, thank the staff at the Medical Society as well as our lobby team, all who work together to on behalf of both the physicians in our state and our patients.
Very good. Okay, we're going to wrap this up, but I'd just like to point out there will be some future podcasts that are in the making at the moment, and some of these podcasts will be about topics that I'm going to mention briefly here. One is dementia, which will have a neurologist come in and discuss all the types of dementia and how to diagnose it, how to be aware that it's a possibility if mom or dad seems to be forgetting things. Psychedelics in medicine is another topic we're going to be doing. That's a bit controversial, but recent studies have shown that certain psychedelics may be helpful in treating intractable depression, PTSD, and a lot of other things. I'm also going to have a physician expert come in and discuss vaccines, and obviously another controversial issue at this point in time. Food as medicine is coming up next sometime in mid-July. And we also, as we usually do, have future legislative issues, at which time we will call Dr. Henderson in, who will still be our chairman and probably going to be chairman of the Legislative Committee for life. And lastly, another one lined up is about hospice and how that all works. So this is Dr. Nick Biasotto saying goodbye for now, but we'll be back with many more issues in the future. And if you want to discuss any of the things that we have in our past podcasts, or want to comment on any of them, or add any ideas that you might want to hear about, please contact us through healthcare.reality@medsocdel.org. That's healthcare.reality@medsocdel.org. Bye for now.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.